Good afternoon, everybody. My name is Ms. Madhulika Joshi. I am one of the obstetrician and gynecologists. I am working in UK as consultant in this post for last 20 years. Today I am going to present hypertensive disorders in pregnancy. This presentation is prepared by myself and my trainee Dr. Hiba Khan. So first of all, there are different types. One is the chronic or the pre-existing hypertension. One is gestational hypertension or pregnancy-induced hypertension. Then there is a preeclampsia and eclampsia. So first of all, before we go into the details of these disorders, I would like to explain about physiology, what happens physiology in pregnancy, what happens to the blood pressure. So in first trimester, there is a fall in blood pressure, and it's mainly due to the pregnancy hormones. They cause the vasodilatation, and also by prostacyclin and nitric oxide. So from beginning of the pregnancy till about 22 to 24 weeks, the blood pressure is quite low. At 24, it reaches to its lowest point, and after that it slowly starts to go up to it, and it returns to its pre-pregnancy level. Post delivery also sometimes it decrease, but then again it goes up for first 5 to 7 days. Early postpartum period, which is about 7 to 10 days, there is a transient hypertension indicating vasomotor instability. So how we diagnose hypertension in pregnancy? So there are different diagnostic criteria. One is that if there is a systolic rise of 140 and diastolic 90, that is 140 by 90, we call it as a hypertension in pregnancy. But relatively is if there is a rise of 30 millimeters of mercury in systolic blood pressure or 15 millimeter of rise in diastolic blood pressure from the initial booking, we label the lady as the hypertension in pregnancy. We have to take into consideration as to when we are doing the blood pressure, as the blood pressure will fall in first half of the pregnancy. And also towards the later part of the pregnancy, because of the gravid uterus and slow venous return, the blood pressure will change. Hence, when we are diagnosing a lady with hypertension in pregnancy, we have to take these things into consideration. Always try to make the lady sit in a comfortable position. The dynamo or the blood pressure monitoring machine should be at the level of the heart. If the lady is in lying down, make sure that she is not lying in supine position, if possibly on the left lateral position. So first of all, I would like to touch a little bit on chronic hypertension. It affects about 3 to 5% of pregnancies. The incidence of chronic hypertension in pregnancy, chronic hypertension is increasing because of the increasing maternal age. We diagnose it, either the lady will have pre-pregnancy history of high blood pressure, or at the time of booking her blood pressure will be around 140/90 or maybe more, specifically before 20 weeks of pregnancy. The challenges in diagnosis of chronic hypertension is, as I mentioned, the blood pressure will fall in first trimester, and this will mask that the lady's blood pressure is normal. And later on, when pregnant blood pressure starts to go up after the 24-25 weeks, we may label it as a gestational hypertension. In fact, it's a chronic hypertension. Some cases may diagnose only postpartum and again labeled as a chronic hypertension. Rarely the preeclampsia occurs before 20 weeks, but they are very, very rare. There are risks associated with chronic hypertension. If it's a mild, it's still associated with risk of preeclampsia. Also it is associated with placental abruption and fetal growth restriction. And mild chronic hypertension is quite easy to manage with the tablets or medications. However, severe chronic hypertension, where the diastolic goes above 110 millimeters of mercury before 20 weeks, it carries significant risk of preeclampsia, which is around 46%, and there is increased risk of maternal and fetal morbidity associated with it. So, as I mentioned, the pre-existing or chronic hypertension, it is present before 20 weeks of pregnancy, or the lady is known to have the high blood pressure. There are different causes of high blood pressure or essential hypertension or chronic hypertension. I am not going to go in details of this, but I will just mention few causes of this hypertension. One is of idiopathic or unknown etiology. One is the secondary to the renal disorders like a glomerulonephritis or pyelonephritis, or cardiovascular disease like coarctation of aorta, or maybe endocrine disorders like pheochromocytoma or diabetes. Obesity is associated with high blood pressure as well. The effect of the pregnancy has got effect on chronic high blood pressure, but it's a beneficial effect in first half of the pregnancy as it lowers the blood pressure, but rarely it can cause deterioration of underlying problem. However, the chronic hypertension can have effect on the pregnancy, mainly the maternal. If it is uncontrolled hypertension, then it can cause cerebral bleed, as well as it can lead to superimposed preeclampsia or eclampsia nearly in about 20% of cases. The chronic hypertension also causes problem with the baby or the fetus. It can give intrauterine growth restriction or intrauterine fetal death, as well as placental abruptions. The treatment of chronic hypertension is usually it's based on the medical treatment. All measures should be taken to avoid preeclampsia or severe preeclampsia. Rest, hypertension are the main two things, and I'll come back to hypertensive or the medications in a minute. Second category is pregnancy-induced hypertension, or we diagnose them as gestational hypertension. So, hypertension which is developing in second half of the pregnancy in previously normotensive woman without any significant proteinuria or edema is labeled as pregnancy-induced hypertension. Again, it has got the caveat that these ladies, were they hypertensive before pregnancy, we do not know, but we label them as hypertensive once we diagnose them after 20 weeks. It affects about 6 to 7% of the pregnancy. It usually resolves 6 weeks after the delivery. It still carries the risk of preeclampsia, about 15 to 26% of the cases. However, if it is diagnosed later part of the pregnancy, there is a low risk of developing preeclampsia or any severe complications related with it. Pregnancy-induced or gestational hypertension is a transient hypertension, but it is associated with preeclampsia and sometimes eclampsia, which is a combination of preeclampsia and convulsions. So, preeclampsia, which is one of the important part of today's talk, the incidence is about 5 to 10% of population in the United Kingdom. Preeclampsia, it typically occurs after 20 weeks of pregnancy, and it's a triad of high blood pressure, proteinuria and edema along with the lady's symptoms. So, proteinuria is usually more than 0.3 grams in 24 hours. Edema we used to consider as a significant finding, but due to its non-specificity is not taken into consideration unless there is a proteinuria and high blood pressure, where it can sometimes manifest as an intrauterine growth retardation, and then retrospectively when the investigation and all. Now I'll be talking about preeclampsia, which is one of the important topic of today's talk. The incidence of preeclampsia is 5 to 10% in population. Preeclampsia is a combination of high blood pressure, proteinuria and edema. It typically occurs after 20 weeks of pregnancy. The proteinuria should be more than 0.3 grams in 24 hours. Edema, initially it was an important feature, but due to its non-specificity, it's not taken into consideration on its own. However, in combination of raised blood pressure and proteinuria, it's an important finding. Sometimes the preeclampsia can be diagnosed only after detecting an intrauterine growth restriction. It is quite an important medical condition in pregnancy, as it can lead to eclampsia, which is a combination of high blood pressure or preeclampsia with convulsions. And it can also it can also cause HELP syndrome, which is a combination of hemolysis, low platelet and elevated liver enzymes. It affects 5 to 6% of pregnancy and up to 25% in women with pre-existing hypertension. The eclampsia or the eclampsia can occur in about 1 to 2% of pre-eclamptic pregnancies in United Kingdom. The significant maternal risk is placental abruption, intra-abdominal bleed, cardiac failure or multi-organ failure. It also causes intracerebral hemorrhage if the systolic blood pressure is significantly raised. There are fetal risks associated with it, that is growth restriction, placental insufficiency and prematurity. There are certain predisposing factors for having preeclampsia. One is primigravida, that is first time pregnant mothers. They are more at risk than the multigravida who have children in past. This is the theory speculated is that this first exposure of the semen can cause the high blood pressure. The second one is pre-existing hypertension. These ladies are already at risk of having high blood preeclampsia. Past history of preeclampsia in their previous pregnancy or family history of preeclampsia. Whenever there is a big placental mass, or we call it as hyperplacentosis, which happens in multiple pregnancy, hydatidiform mole or diabetes mellitus, there is a high risk of having preeclampsia. There are different theories as to why the preeclampsia happens. There is nothing is behind the happening of the preeclampsia. One of them is the uteroplacental bed. Whenever the embryo implants, the trophoblast and syncytotrophoblast, they invade the maternal vasculature and they cause the maternal vasculature as the low resistance blood vessels, so that the blood can flow very easily through these vessels, and this is independent of the maternal blood pressure system. However, in ladies with the preeclampsia or the ladies who are at risk of developing preeclampsia, it is found that the trophoblasts do not invade the maternal blood vessels very well. That is, there is an ineffective or defective invasion of the trophoblast into maternal blood vessel, which leads to narrowing of the maternal blood vasculature, as well as sometimes some clots or atherosclerosis of these vessels. This is also found in ladies who are not pre-eclamptic, but they have got systemic lupus erythematosus or some other medical conditions like pyelonephritis or glomerulonephritis. However, this is the most speculated theory. We also call it as a hypoxic placenta, where the placenta is not getting enough oxygen due to incomplete invasion of the maternal bed on the placenta. There is also immunological or genetic factor associated with it. Renin, which is one of the important hormone in managing or in controlling the renin-angiotensin system, is also an important, and it is found that the woman with preeclampsia, the level of hormone called renin is low. However, in some pre-eclamptic women, the renin is found to be normal, hence it is not also found in each and every woman of preeclampsia. There are also other factors like prostaglandins, neutrophil or natural killer cells, which can be responsible for developing preeclampsia. However, the exact cause as to why some women develop preeclampsia is still not known. There are some changes happen, which as I discussed, that is vasospasm. There can be some coagulation changes and can have sodium and water retention, which can give edema. The signs the mother will have is the high blood pressure, usually much more, about 160, 110 or 150, 100. Proteinuria, which is quite significant, as well as edema, especially the ankle edema. As I mentioned, high blood pressure right in the beginning, that booking blood pressure is about 30 millimeters systolic and 15 millimeter rise in diastolic blood pressure. Also proteinuria, or we also call albuminuria. The urinary protein greater than 0.3 grams in 24 hours. However, to collect the urine for 24 hours and then give it to this lab, it's quite a tedious job. Hence, we converted it to a PCR, that is a urinary protein creatinine ratio. The result comes very quickly, and it's a random sample, two samples 6 hours apart. And if the level is more than 15 to 30 milligrams, then we label as proteinuria. It also indicates that there is a glomerular changes or damage secondary to high blood pressure. Edema, Previously, we used to weigh the ladies at each and every antenatal visit. However, we do not weigh these ladies anymore. But it is documented in the literature that there is a weight gain of more than 1 kg in 1 week or 2.25 kg in any 1 month is a significant edema. It is present in about 2/3 patients of pregnancy-induced high blood pressure, but however, many of pregnant ladies who develop preeclampsia do not have the edema. The symptoms the lady present with preeclampsia mainly is the headache. Usually we call that the headache is frontal, but it can be occipital, but sometimes it's a generalized headache woman present, and it is due to cerebral edema and secondary to high blood pressure. Visual disturbances like blurring of the vision, flashes, flight or blindness, or sometimes they may say that they can see stars in front of their eyes. Epigastric pain or right upper quadrant pain, which is a significant finding of severe preeclampsia, and this is due to the enlargement and subcapsular hemorrhage of the liver. It may be associated with nausea or vomiting, or many women will complain that they are not feeling well, and they will just complain as a generalized symptom of not feeling well. Oliguria or anuria when the kidneys are damaged significantly, which is again quite a severe form of preeclampsia. So this is just a pictorial diagram. So it is the diagnosis is the high blood pressure, vision changes, persistent headache, sudden weight gain due to the water retention, shortness of breath, it is because of the pulmonary edema, presence of protein, low urine output, nausea, vomiting, abdominal and shoulder pain, again because of this liver capsule edema. When the lady presents with these problems, we need to perform certain investigation which are targeted to preeclampsia. One of the most important is the complete urine examination. Make sure that the lady doesn't have any water infection or urinary infection, as it also can give proteinuria. Hence, the routine urine dipstick is very important, and it is important to send the urine for MSU, that is for the culture. The kidney function or the renal function is important, and if the uric acid is more than 6 mg/%, it's quite significant finding. However, we have to look into the creatinine level as well into the renal function. We also check the liver function to check level of albumin as well as the transaminase levels. Coagulation status is usually checked when there is severe form of preeclampsia. Mild form we check once only, and it includes platelet count, fibrinogen and fibrin degradation product to rule out that there is no DIC, which can be a complication of the severe preeclampsia. We used to do the fundus examination to rule out any retinal problems, but we do not perform this anymore. There are risks associated with baby as well, and we need to make sure that the fetus is doing well. Hence, we do an ultrasound scan to make sure that there is no oliguria or oligohydramnios, and the fetal growth is normal. We also do the non-stress test, that is called CTG or cardiotocography, which is a monitoring of the fetal heart. Imminent eclampsia. It is a condition when the eclampsia continue to deteriorate despite treating it, and when the blood pressure is significantly raised to 160/110, associated with significant proteinuria, hyperreflexia and continuous headache. Epigastric pain is one of the important findings, and it can lead to convulsions, which can be a significant risk to the mother and the baby. I have just put this chart to compare the difference between preeclampsia or existing or chronic hypertension. And it's just the recapitulation of the slides which I mentioned earlier. So the preeclampsia usually happens in prima gravida, but not that much in chronic hypertension. Hypertension in preeclampsia is usually diagnosed after 20 weeks, but in pre-existing it may be present before 20 weeks. And ladies who have got the high blood pressure before pregnancy, it is important that they should have a pre-pregnancy counseling. Proteinuria is usually present in preeclampsia, but it is a late onset. First the high blood pressure develops and then proteinuria. However, in chronic hypertension, it can be already present due to the renal damage. Serum uric acid is not increased in proportionate to serum creatinine in preeclampsia. However, in chronic hypertension, they are in proportion. So, there are differential diagnoses of high blood pressure, proteinuria and edema. There are differential diagnoses. There are other causes of hypertension, proteinuria and edema. I already discussed about high blood pressure. Regarding proteinuria, if there is an excessive vaginal discharge, which in some pregnant women can happen, which is a physiological, can give significant proteinuria. Hence, it is very important to collect a clean midstream urine sample, which again in a pregnant woman, especially in advanced pregnancy, is difficult. Urinary infection, as I mentioned earlier as well, hence it is important to send the urine for culture and sensitivity test. Other medical causes like congestive heart failure, severe anemia can present as just with the edema. Orthostatic proteinuria, it is detected at the end of the day while it is absent in the morning. Hence, in past we used to do the 24-hour collection, urine collection, which is more accurate. Edema, if there is any medical cause like cardiac, hepatic or renal problem, then the edema can happen. Even in pregnancy, it's a normal physiological edema due to the pressure of the gravid uterus preventing the blood flow coming back towards the heart from the pelvic veins. If there is a thrombosis, deep vein thrombosis, however, it will be a unilateral edema present in these cases. What complications can happen with the preeclampsia? So, there is a maternal complications like convulsions or cerebral hemorrhage, multi-organ failure like renal, heart or liver failure. It can cause DIC, abruption, HELP, or it is found that in about 1/3 of cases the hypertension will continue and change into the chronic hypertension, and it can happen in subsequent pregnancies as well. With baby, it can cause intrauterine growth restriction, fetal death and prematurity, which is iatrogenic to protect the mother. Treatment is prophylactic and curative. So, in prophylactic, it is very important to detect which woman is at risk of developing high blood pressure in pregnancy. And history is very important, family history is important. Also, in our hospital, we do a Doppler study at 20 weeks for all these high risk women, where we look for the blood flow going through the umbilical artery, and if there is a restriction of the blood flow going through the umbilical artery, these ladies are at risk of developing either high blood pressure or IUGR baby, and we commence these ladies on low dose of aspirin, which is 60 initially, but now it is 75 to 150 milligram, and it helps in preventing these complications. Curative, there is only one treatment, one curative treatment is the delivery of the baby and the placenta, and it corrects the preeclampsia. So, general measures I have already discussed with you, so I will just go through it quickly. It is important that we monitor, if the lady is admitted to the hospital, we monitor their blood pressure regularly, check their urine for proteins. As I mentioned, we do not weigh the ladies, we do not do the fundus examination, however, the literature does mention these things. And regular blood test, for mild we do once a day, but however it is severe preeclampsia, then we do twice a day or sometimes every 6 hours. Fetal monitoring, daily fetal movement count, fetal sonography is very important, and non-stress test, that is the CTG monitoring. We have got the nice guidance on the preeclampsia as to how to manage these cases of hypertension and severe hypertension. This slide shows guidance from NICE regarding the high blood pressure, which is mild, and the severe high blood pressure. Usually the mild cases are managed as an outpatient. We commence them on antihypertensive treatment, and we monitor them twice a week in our day assessment unit, which is like an A&E for the pregnant ladies. We do the bloods, if the blood pressure remains stable, we do the blood test every week, we do the cardiotocographic monitoring of the babies, and we do serial scanning 2 to 4 weeks. However, if they got a severe hypertension, we admit them in the hospital, give them medication, control the blood pressure, and monitor them every 4 to 6 hourly once the blood pressure stabilizes. Again, the ultrasound scan monitoring of the baby every 2 to 4 weeks, every 2 weeks, and the non-stress test or the CTG monitoring every 6 hours or sometimes twice a day. Once the ladies with the mild high blood pressure, if they are well, they go home. Same thing with the high blood pressure, severe hypertension. They stay in the hospital till their blood pressure stabilizes and they're responding the medications very well. We send them home to be monitored in the community quite regularly. Now I'll discuss about the medical treatment needed for the preeclampsia. The whole treatment is mainly to protect the mother, as the high blood pressure can cause cerebral hemorrhage and can cause maternal significant morbidity as well as mortality. So whole idea is to maintain the blood pressure around 140/90. If it drops too much, it can cause placental hypoperfusion and can cause fetal compromise. So always try to maintain the pressure around, blood pressure around 140/90 or 150/90. There are some limitations of the treatment, is that there is no evidence that these medications will prevent the underlying pathology, and also the dietary changes or rest is not advised. So this graph shows the guidance how to manage the severe high blood pressure, that is over 160, 110. You admit them, give them nifedipine slow release 10 to 20 milligram or labetalol. And after an hour, check their blood pressure. If it is still high, then we give labetalol as an IV infusion, IV bolus dose, and then we maintain as an infusion. If the blood pressure is still remain high, we give hydralazine either first in the bolus form and then we continue as an infusion. And during this time, strict monitoring is very important. So once it's important to stabilize the mother, control her blood pressure, and the whole idea is to prevent fits or convulsions. And if there is a suspicion that the lady will develop convulsions, we put them on magnesium sulfate, which prevents the cerebral edema and reduces the risk of convulsion. Regarding the monitoring, it's important to monitor maternal vital signs like respiratory rate, pulse, oxygen, initially every 15 to 20 minutes and then gradually half an hour, and once stabilizes 2 to 4 hours. A strict input and output chart is very important. Neurological status need to check every few hours, and the fetal monitoring. If the lady is in labor, make sure that you do a continuous monitoring of the baby. Lady can have epidural analgesia as a pain relief. She can have a normal vaginal delivery, and if needed, we can give more medications during labor to control her blood pressure. In third stage, which is after the delivery of the baby, we give them syntocinon, but not symptometrin or ergometrin, which can increase their blood pressure significantly. And it is important to monitor the blood pressure after the delivery as well. So if the lady develops eclampsia, which I will show again in slide in few minutes, it's very important. It's a medical emergency, and it's important that we get the ladies, we get the staff to help this lady. So as soon as the ladies start to develop convulsions, we call for help. We maintain their airway, breathing, and circulation. We give magnesium sulfate to control their seizures or convulsions, and sometimes we may have to give some sedatives if the convulsions continue. This is again the overall chart, which is showing how to manage the severe preeclampsia or imminent eclampsia. It's very important that we should not be overloading these ladies with the fluid, as it can cause RDS or pulmonary edema. We have to decide when to deliver. If the blood pressure gets controlled, then we can delay the delivery till the baby reaches to 34 or 36 weeks of pregnancy. But if the maternal condition is deteriorating despite giving all the medications, then it is important to deliver the baby. Delivery is the only treatment for any form of preeclampsia, be it mild or severe. There are certain indications for the fetus as well to deliver when there is a severe intrauterine growth restriction, oligohydramnios, it means there is hardly any fluid around baby, reduced fetal movement, or the heart rate on the cardiotocography is abnormal. Also, if maternal condition is deteriorating or she is showing signs of DIC or imminent eclampsia, then the delivery is indicated. The method or the mode of delivery depends upon if the lady is already in labor, we can do the rupture of the membrane, put the drip for oxytocin and get the lady delivered. Usually these ladies deliver fairly quickly as the body is in process of terminating the pregnancy. However, sometimes we may have to do the cesarean section which is obstetrically indicated, especially if there is a fetal distress or any abnormality with the cardiotocography monitoring, or the lady has got other indications or malpresentations. During labor, it is important to do the proper intrapartum care, close monitoring of fetus with continuous CTG is indicated, proper analgesia, specifically the epidural if there is no problem with the platelet is indicated. Second stage should be shortened using the forceps or venous delivery called as instrumental delivery. Postpartum, very important to monitor in first 48 hours to 5 days, because about 46% of women will develop eclampsia in this period. Hence, the lady should be hospitalized and should not be rushed to discharge home. There is a recurrence risk of the high blood pressure. So, the earlier the high blood pressure or preeclampsia delivers, there is more recurrence risk. But if it develops later on, then there is a less risk of developing preeclampsia in subsequent pregnancy. And 1/3 of these women will develop chronic hypertension later on in their lives. There are some long-term cardiovascular risks associated with these ladies who develop severe preeclampsia. Is that they continue to develop chronic high blood pressure. Later on in life, they are at risk of developing ischemic heart disease. If there is any underlying condition like dyslipidemia, insulin resistance, these women tend to develop, or they are more prone to develop these conditions. Very important to tell these ladies about the late onset of cardiovascular diseases with ladies with history of pregnancy induced high blood pressure. Hence, annual blood pressure check is recommended. I will touch I have discussed a bit on eclampsia, but I will touch in short about eclampsia. It is a condition when the preeclampsia is complicated with generalized tonic-clonic convulsions, or the lady can go into coma. The pathophysiology of eclampsia is similar to preeclampsia, but significantly intensified. There are 4 stages of convulsions. One is the pre-monitoring stage, where lady will start to feel unwell, which change into tonic and then clonic stage. Usually the tonic-clonic stage lasts for 1 to 4 minutes, and then the lady can go into stage of coma, which can last for a few minutes to few hours to few days. The management, as I explained in my previous chart, is to maintain airway, breathing and circulation. All attempts should be done to arrest the convulsion. Women may need ventilator support, hence the presence of anesthetist or ITU team is very important. The treatment of it is delivery or the termination of the pregnancy. We also have to make sure that we prevent all the complications happening after eclampsia and the postpartum care these ladies need. So once these ladies develop eclampsia and after delivery, we keep them in our high dependency unit, where they get quite rigorous monitoring of their blood pressure and all other parameters, be it biochemical, for first 48 hours. The specific management involves magnesium sulfate, which is the wonder medication for the eclampsia. Very rarely we give sedation to these women. Maternal support is very important. And this is again the chart which is showing that if the lady develops eclampsia, you give anticonvulsant, that is Maxsulf. If blood pressure is significantly raised, despite giving magnesium sulfate, you put them on antihypertensive. Diuretics, we do not give diuretics in pregnant women unless they have got significant pulmonary edema, as the diuretic will deplete the intravascular volume, which is a problem in preeclamptic woman. If the lady is in labor, deliver them. If not in labor, and if the fits are controlled with these medications, then follow these things. If the lady is term, delivery. If it's preterm, give them steroids for the fetal lung maturity and deliver, be it cesarean section or normal delivery. If the fits are not controlled, then we have to intubate the lady and do the cesarean section if the cervix is unfavorable. Thank you very much. Hope you enjoyed this talk. Hope to see you all again.